The Suncoast Gerontology Center is a relatively new organization within the medical center of the University of South Florida. It was developed because basically we have here in the southern part of Florida a demographic and geographic imperative to focus on the healthcare problems of the elderly. Florida is a state with the largest proportion of elderly of any state in the United States, with 18% over age 65. The Tampa Bay area, which is a retirement area, actually has 4 of the 5 surrounding counties with a population of 33% of the population over age 65. For that reason, we felt that we had a special responsibility and a special obligation to focus on healthcare problems of the elderly. Now, one of the most significant healthcare problems of the elderly population is dementia. And for that reason, we've undertaken a number of research projects and a number of educational projects that deal with the appropriate care and recognition of patients with Alzheimer's disease and the effect that this disease has not only on the patient themselves, but also on the physician, on the family members, and on the surrounding community. Hello. I'm Dr. Eric Pfeiffer, director of the Suncoast Gerontology Center here at the University of South Florida in Tampa. Welcome to our film series entitled Understanding and Coping with Dementia. The purpose of our film series is to delineate the physician's role in helping the patient and his family coping with dementia. We have a 3-part series on the topic of dementia. The first film in this series will focus primarily on the process of diagnosis and recognition of the disorder. The second film will take us into the continued management of patients and their families with dementia. And the third will focus on the longer-term course and outcome of dementia. We'd like to show you now first a few interviews with patients and with family members where the patient has developed the various stages of dementia, usually of the Alzheimer's type of disease. And I think you will recognize quite a few of the patients in your practice. Now, Mrs. Moore, you went through a kind of a discovery process where you became aware that something was going on with your husband. Could you tell me when that sort of discovery process began?
Well, I think over the 10 years that I'm familiar with it now, I look back, and of course those things just had different meanings at that time, but it came on like, sort of like rain in the night. It was, just came on, and then it was suddenly, by the end of 10 years, it was a flood of anguish. But there was a soft rain at first, and I didn't know what it was, and kind of unaware of it happening. And little things came up that usually we'd been married 25 years, and we have our own little pattern. He does things and I do things. We worked things out sort of 50-50. I do the shrubs, he does the lawn type of thing. And in driving, sometimes we'd take a trip, and I was sort of the co-pilot. He always loved to drive. And I would read the map, and I would say, well, all right, up the road about 5 miles, we're going to hit a fork. I want you to take 98 or something like that. And then I would settle down and expect him to take 98. We'd get up there, and I would suddenly be aware that he wasn't going right nor left. He wasn't doing either, and I would get panicky. And then I would say, take right, and he would immediately say, that's what I was going to do. He compensated a lot. And so if I didn't say anything, and he took left, and I said, well, I told you back the way where you were to take right, then he would say, would you get off my back? And I would be kind of attacked again, so I would kind of say, well, I don't want to nag about it. And but it was worrying me, those little things, because very often, I think the most puzzling thing was when he would talk over the telephone to friends. We maybe had made arrangements like, let's get together tonight. And he would answer the phone, and so I would be wanting to know when they're coming or what to prepare, and I'd say, well, what did they say? Are they coming over? And he'd say, well, I don't know. And so, of course, I just jumped right in like myself, and I'd say, what do you mean you don't know? You just talk to them.
My father had been having some problems in his job that my mother had mentioned to me a few months before, and had mentioned that she was puzzled by them, peculiar kinds of behaviors not characteristic of him and inappropriate in situations. And eventually this led to questions being raised at the company where he worked about his ability to continue doing his job. He talked very little about his job, and in fact it was only in the process of the diagnosis of the disease that we found that little by little the company had removed responsibility from his job so that the operation could work around him, so to speak, because he became less and less able to execute his responsibilities. And from New Orleans, I believe it was at that time that he went in for, well, first a physical, which proved him to be a splendid specimen with no ills whatsoever, which is remarkable in retrospect, that a very thorough physical showed no detectable medical problem whatsoever.
And he said, there's something happening in my head that I don't understand. And he'd been a scholar. He had 2 graduate degrees. He had studied in Oxford.
Yes.
And had studied at the British Museum, but he could no longer do his research. And I think he realized he couldn't read. He'd get maybe the first 5 words and couldn't remember the first.
I see.
So.
And how did he react to that?
I think he was very puzzled, and I think inwardly alarmed, but still maintained enough of his own mental capacities to try to keep that from the family.
I see. So he was trying to hide it from
Yes,
you too?
yes,
From
I
you
think
too?
so. Except once in a while he would express himself that there was something happening in his head and he didn't understand it. And then made a joke of the fact that you just have to give up reading that paper. There wasn't any news in it worthwhile.
So it was sort of a way of
Yes,
adapting to
yes. So I think he realized this himself.
One other time you'd mentioned that he had a kind of a good sense of humor about this, and
An excellent
maybe
sense
that
of humor.
helped him.
And I think that's part of it, that he did have this good sense of humor.
And as you saw him declining, what was your reaction to it?
Well, it was to me a waste of a wonderful mind.
Yes.
And that's been the worst.
To see your
Yes.
husband's mind.
And to see a person who, is active and then no longer can handle themselves, that is, the falling and the
He had falls.
unbalancing the body and the pitching forward, unable to make any decisions for himself.
He did come to Florida to retire.
You had a dream to come here and
To
retire.
retire, that's right.
What did you envision?
Well, we had a new home, and he was retired, and we could do a lot of things that we couldn't have done before. The children were all grown up. We were going to live again. And then he got sick. And we got tied down with the illness.
Tied down.
That's, how else could I put it? Our friends, our long-standing friends that we had down here, don't even bother to come and see us anymore. I'm angry about that, because they can't converse with him. So I guess they figure, why should we bother to go see him? And I don't think that's right either. Do you?
Do you wish they were a bit more accepting and more tolerant?
Yes. As a matter of fact, I told one couple what I thought of that for them not coming to see me.
Tell me
Now,
what you told them.
I just told her. My husband grew up with this man from the childhood. And they saw each other. As a matter of fact, they were the reason we moved down here. And they're very good friends.
Really?
Yes. As a matter of, we're married 39 years. As a matter of fact, they got married the same day we did. We had a double wedding ceremony. And then, since he got sick, the visits became more infrequent. And all of a sudden, no visits at all. Finally, she calls me one day. And then I blew my top.
You let her have it.
I let her have it, and she must have told him, and we haven't seen them now for about 6 months. So they weren't very understanding then. And they weren't true friends.
Dementia is really a very devastating disease. We still currently do not understand its exact etiology, and we certainly do not as yet have a treatment available for the disease. There are a number of avenues that are being tried experimentally, but the treatment for dementia is not yet available. So what we are faced with really is in assisting patients to cope with the dementia while research goes on to try to find an answer. When we're talking about coping with dementia, however, I'd like to share with you a kind of an approach that has been useful to me, and that is to think that really all three of the individuals involved in the care of the dementia patient have to make certain adaptations. I'm talking here about the patient who has to adapt to his disease, the family members who have to adapt to the patient's changed circumstances, and importantly, the doctor who also has to adapt to this very difficult to treat illness.
I don't think he even mentioned the word, he had written it down. But I feel that at that point, here was a teaching hospital. I should have gotten some guidance at that point on what to do.
When they told me what he had, I says, well, what should I do about it? Will he get better? He says, no, ma'am, he'll never get better, he'll get worse. I said, and then what'll happen? He says, well, if you can't take care of him, put him in a home. And I didn't like that answer. That just threw me. And I had to drive 70 miles home with that thought in my head, with my husband being released from the hospital that day. How would you feel?
I told the doctor I would like to talk to him alone. And I was ushered in the room with Harold still in his gown, up and down the back, sitting on a chair in the corner, and to discuss these things that I felt that Harold had been defensive about, and that he knew that he was terrified probably of what was happening to him, and that no one else seemed to be aware except me. And I didn't want to point out I just didn't want to point it out in front of Harold. Do you know what I mean?
So
I want to talk about him.
was in front of him.
Yes.
What about him?
Yes, and that always happened when I was talking to the children. He was on the other line. I never got to say, Dad's doing funny things. And I wanted to tell the doctor that. Well, he proceeded to sit at his desk and he read off all the tests. This is good. And so he said, I think it might be a slight depression. I still hadn't been able to put my 2 cents in, and so at that point I just blurted out, could it be hardening of the arteries? And I didn't even know what that meant. I just heard old people talk about hardening of the arteries. And that's the only thing I could think of to say. He had his back turned to me, and he turned around real quickly, and he said, well, that wouldn't do you any good to know. That's not curable.
The talk always was about hardening of the arteries. This was the thing, and this was the thing that you had to live with, and nobody could do anything about that.
The only word that I was given was organic brain syndrome. And after thinking about it, I was very bewildered and just couldn't figure it out. I didn't get any more information than that. I would have appreciated very much if the doctor had just taken a few minutes and said to me, he has Alzheimer's disease. It's not going to get better, it's going to be worse, and it's going to be gradually going downhill. But I think, too, doctors are people, and sometimes they're just a little bit reticent about telling you something that is really unpleasant.
When I'm talking about coping on the part of the physician, that is getting an intellectual handle on what is this disease process all about. I think we as physicians need to understand what the physiology is, what the consequences, what the sequences of events are going to be. The same goes for the patient and the family. In order for you to know whether your patient has in fact got symptoms of organic brain disease, we have developed a short, portable mental status questionnaire. That questionnaire consists of simply 10 questions that you can ask your patient, either at the bedside or in your office, and that you can record very rapidly and get a quantitative measure of the degree of organic brain disease if it exists at all. I'd like to share these questions with you. Each requires a correct or an incorrect answer. You simply total the number of errors that the patient makes. Mr. Moore, I wanted to ask you a few questions that are sort of school-type questions. Just try to do the best you can with them. Even take a guess at the answers if you don't know them for sure.
Okay.
Let me ask you, what date is it today?
Mm-hmm.
Do you know what date it is today?
Mm-hmm.
What month and what day and what year? Like, is it 1900 and what?
Yes.
In order to score correct, the patient has to give both the month, the date, and the year. The second question is, what day of the week is it today?
I thought everybody knows. Let's see. I haven't been paying any attention.
Is that right?
I really don't know.
The third question is, what is the name of this place? And any correct identification, this is the hospital, this is my home, this is Dr. So-and-so's office, is accepted as a correct answer, if it is in fact correctly identifying the place. The fourth question relates to, what is your telephone number? A fifth question, how old are you now?
75,
And what is your birth date?
April 6, 1906.
The sixth question asks his birthday, and the birthday requires both the month, the date, and the year. Now, you may be interested to know that it is harder to remember one's age than one's birthday, because the age has to be updated each year, whereas the birthday remains the same. The seventh and eighth questions are, who is the President of the United States right now? And the next question is, who is the President just before him? The ninth question is, what was your mother's maiden name?
Rose, well, her name, she was married down on Rose Simmon.
Rose
Simmon?
Simmon.
Mm-hmm.
And what was your maiden name?
Vera Dannon.
Say that
Vera
again.
Dannon.
Dannon.
Dannon, D-O-W-N-U-N.
Right. All right. All right. Okay. Now I want to ask you to do a little math for me. And the final question is a series of mathematical calculations. Would you subtract 3 from 20?
17,
And keep taking 3 away from each
14.
new number that you get.
14, 11, 8, 5, 2.
Okay. Let me ask you one question before that you almost had the answer to. Who was president before Mr. Reagan? Did that occur to you?
I said Carter, but that's not right. What is his name? Kind of bold-headed. I can't think of it right now. It's on my mind, but I can't think of his name right now.
Let me tell you a little bit about the scoring of this. Individuals who are intellectually intact and who've had at least a high school education can make up to 2 errors without it indicating any kind of degree of organic brain disease. If the patient makes 3 to 4 errors, you can be reasonably suspicious that at least some mild degree of organic deficit is beginning to set in. With 5 to 7 errors, you are seeing a moderate degree of organic deficit. And in a patient who makes 8 to 10 errors, you're seeing severe degrees of organic deficit. Moderate degrees of organic deficit usually mean that the patient can no longer be relied upon to give you a good medical history, can probably not take care of taking his own medication on a scheduled basis, and probably cannot handle complex financial transactions anymore. The patient with 8 to 10 errors probably requires ongoing supervision of his activities, probably cannot even handle simple monetary exchanges, and certainly cannot follow medical instructions because he will not be able to remember them. During the middle stages of the disease, the patient's verbal communications remain quite intact, even though their content of information may be lacking. But as the disease advances and as more brain cells die, even verbal communications begin to become impaired. The production of words falters. The patient engages less and less in conversation and may resort to simply repeating single words rather than forming full sentences. They may begin to not be able to name objects correctly anymore, or not to interpret objects correctly anymore. Okay. What is this part, what I'm wearing? What's that called? A person may be told, why don't you turn off the television, and they will instead go and open the refrigerator door. They may only respond in monosyllables or lose words altogether. Now, as the disease advances, some of the physiological functions become affected as well. The patient may become incontinent, first of urine and later on of stool. It is important to distinguish dementia from acute confusional states, because acute confusional states are potentially reversible. Here, Dr. Patricia Barry discusses the evaluation of acute confusional states.
What do we need to consider in the differential diagnosis of the confused patient?
Well, I think we have to talk about two aspects of confusion. In most cases, the etiology of an acute confusional state, or a delirium, or an acute organic brain syndrome, or whatever term you're most comfortable with, this is usually due to a medical problem in an elderly patient. It is rarely due to a primarily psychiatric problem. And I think that this is one of the areas that we have to be most concerned with in these people, because we don't want to miss an acute treatable medical problem in a confused patient. To make a diagnosis of delirium, you would like to hear a history of a relatively acute onset, in other words, days or hours as opposed to weeks and months. You would also look for alterations in the level of consciousness. Typically, these people are lethargic or have some other alteration in this level. They frequently may be agitated. They may even have hallucinations or other manifestations of what might be considered a psychosis. The most important causes of this state in an elderly patient are the acute medical situations that elderly people can get into. One of the most important of these is a toxic reaction, and frequently this is to some type of medication. Medications can be particularly dangerous in older people if they're given inappropriately, if they're given in too large an amount. The medications that classically can do this are ones that affect the central nervous system. Sedative hypnotic drugs, particularly benzodiazepines, can affect elderly people this way. Antihypertensive medications, many of which have central effects, can also cause this type of problem. Diuretics can cause confusion. Digoxin, anti-Parkinson medications can be at fault. Anticholinergic medications, and any of these things can, in any elderly patient, result in an acute confusional state.
What kind of workup do you do for the acutely confused patient?
Basically, you need to do a good medical workup. You need to start with a thorough history, particularly concentrating on medical illnesses and on medications. The past medical history is extremely important, as well as the history of the present condition. The history is then followed by a very thorough physical examination with particular attention paid to the lungs, the abdomen, the bladder, and a neurologic exam is, of course, an extremely important part of this workup. The laboratory that you need to obtain are, in many cases, routine for this type of a workup. You need a CBC, you need serum electrolytes, you need blood sugar. An SMA complete would be an appropriate test to order to check such things as the calcium, the creatinine, VUN. You also need to check the EKG. You're looking for evidence of an arrhythmia or a myocardial infarction. You need to look at the chest x-ray very carefully. You need to look for other evidence of infection in the patient. Such things as a urinalysis and culture and sensitivity may be appropriate. You really need to do the type of workup that is geared toward diagnosing an acute medical problem in a patient who is ill. And I'd like to emphasize that this acute confusional state, when it accompanies a medical illness, is a very serious condition.
To get a better understanding of this disease, we'd like to follow a couple of families in some detail. The first of these families is the Moore family. The patient, Mr. Harold Moore, now quite seriously disabled and demented. Mrs. Marion Moore, his wife, also the oldest son of the Moores, Preston Moore, and his wife, Mary Moore. The younger Moores have actually made a tremendous sacrifice in trying to be of help to Mrs. Moore in assisting her in caring for her husband. They've moved from California to be with the father in Florida.
I was not able to find a job, but I was willing to go along, figuring it would work out.
You were working out there?
Yes. Yes, I'm a newspaper reporter. We would have these hours-long phone calls cross-country that just seemed to be so much wheel spinning. And I knew at the time it was very valuable for Preston's mother to spin those wheels. They needed to spin. At the same time, there was little feeling on our end that we were really making an impact and giving her any help.
So you considered what else you could do?
Right, we considered moving. And in fact, we did move.
To be here?
To be here, yes.
I think the times ahead for my father are going to be increasingly difficult. When I have thought in the past about his future, the image that I have in my mind is of someone sitting in a small rudderless boat drifting off into a fog. And my mother is sort of there as the first mate, and you know, she can't bring any more compass or rudder to it than he can. Well, maybe that isn't so, perhaps a little. She can be there and be with him, and I think she's made a commitment to doing that. She's chosen that, and chosen it in a very powerful way. And so that's what their future together will look like. And I think ours will be to try to find ways to support that. And the biggest thing that means, I think, is to be emotionally in touch with what is happening. Just to get what's happening, really get it, not just intellectually understand it, not just be there to stand around and be the supporting people, but just to really get what is going on there so that we can be with her and be with him.
He is reading my body language. I call it his basic personality. But it retreats on me. I need to go retrieve it.
I see.
I need to bring it out again. And because he withdraws. And so it seems sometimes it has to come 100% from me. And I so want my 50 from him.
So you have to take the initiative.
I've gotten over wanting my 50 now.
Yeah, but what brings out the old Harold, his own personality?
Well, it's just simple love and affection.
Simple, you must realize that it's coming from my heart and not my head. That's it. That's it. I'm not trying to make you feel uncomfortable. Not trying to make you anything at all. And you shouldn't blow the chance when you got the chance to say, catch it, go on.